keeping an eye on imaging. Discussion and commentary based on articles from JACC, Cardiovascular Imaging.
Hello and welcome to another edition of the dynamic editorial for the JACC Cardiovascular Imaging. My name is Dr. Chandrasekhar and I am the Deputy Editor of the journal. With me are two distinguished guests, Dr. Pam Douglas from Duke University, who is the leading expert on improving imaging and appropriateness in this country, and then Dr. Leslie Shaw from Emory, who, as you know, has published a lot on outcomes research in imaging. Welcome, Dr. Douglas. Welcome, Dr. Shaw.
Thank you, John.
We are going to discuss a very important topic, which was the outcomes research workshop at the NIH. Dr. Douglas, can you tell me what was the philosophy behind it, and why do we need such a imaging clinical trial setup?
Well, for the last 3 or 4 years, the ACC and others nationally in cardiovascular medicine have really been pushing for more quality in imaging. And as part of that, we've isolated the different components of quality, but one of them is clearly the impact on the patient and the patient's health. And this concept of measuring outcomes in imaging is one that has troubled imagers and others for many years because, as you know, you image and then you, based on those results, you make a decision about therapy and then you implement that therapy and then maybe eventually you'll have an effect on outcomes, but there's no direct link. But the philosophy was that we couldn't be satisfied with just saying it's indirect, can't measure it. We really needed to drill down and figure out how to do outcomes research using imaging, using diagnostic testing. And so the NIH held a workshop to get experts together to say, imagers, clinical trialists, health services researchers, how do we measure outcomes in imaging?
Dr. Shaw and Dr. Douglas, the group was a very august body with many different specialties represented. I'm sure you had difficulties in deciding which modality and how do you test. Do you do multimodalities, real world versus just a selected population? Give me a sense of the difficulties you had in coming to a conclusion. Dr. Shaw first and Dr.
You know, as a participant, and Pam was the leader of this, as well as Alan Taylor and Mike Lauer were leaders of this think tank, if you will. We decided to look. I mean, for every group was different, but we decided to look at imaging modalities in critical areas where imaging was used quite frequently, and modalities for whom there was a strong body of evidence or a suggestion of a strong body of evidence and a strong utility for clinical decision making. I don't know, Pam, if you want to elaborate any more on that.
Sure. We actually didn't look at modalities. We didn't start with modalities. That's where imaging sort of has come from, is always to think of modalities. We started with patients, and we started with clinical questions or clinical situations in which imaging might make a difference. And so we started with primary prevention, stable chest pain, outpatient chest pain, emergency chest pain, acute chest pain in the ER, and heart failure. These are common situations affecting tens of millions of patients in the United States today, where we need to make a choice about testing or not testing, and if you test, which test is better.
Do you have any other sense of?
Yeah, one final question, I think, is it's an area of where clinicians really have heard a lot about this, but perhaps don't really understand what this means, and that is what we're trying to, in imaging, is trying to get to this idea of comparative effectiveness research. And I think at the heart of this meeting was that idea is, can we truly devise high-quality evidence for comparative effectiveness? And while we have this opportunity to educate clinicians who are going to listen to this, maybe you could give us your definition of comparative effectiveness research, because I think we're going to be hearing a lot about this, and it would be great to hear it from you as an expert.
Well, Leslie, that's a tall order, because I think that as a country, as a nation, we're trying to define comparative effectiveness. But if you break down the two words, there's comparing, so you have alternatives. So you have one diagnostic strategy or another diagnostic strategy in the case of imaging. And effectiveness is separated from efficacy, which is a clinical trial where you tightly control everything about what's happening to that patient, except for the one variable that you're investigating. And effectiveness is much more real-world, clinical community, where what happens to the patient after your intervention is up to really usual care, if you will. So it needs to be in the community, not in an academic center, and it needs to be real world.
So heretofore we have looked at the idea of randomized trials, but kind of being in this kind of laboratory setting, and now we're transitioning into this practical trials so that we'll get a better translation of that evidence into real-world clinical decision-making. Is that your interpretation
Absolutely,
as well?
Absolutely. It can still be a randomized trial, but it needs to be in the community and practical.
Very good.
I'm sure the audience must be asking that with the fast-moving technology, fast-moving treatments like the Jupiter trial changing the paradigm of how we are going to treat patients, are we going to be behind the curve each time? By the time we complete a trial with a certain modality or multimodalities, the question may have already been answered and we again climb the hill again and again. Do you see that as a problem?
That is an issue because the technology, imaging is very technologically driven, and advances such as we've seen with CT angio just take the clinical arena by storm. And 5 years ago, we wouldn't have even known how to develop a trial with CT angiography. Now we're using it routinely. And so we do run that risk, but that doesn't mean we can take a pass on stepping up to the challenge here of getting outcomes for imaging.
Sure. Any final thoughts, Dr.
No, I
Shaw?
think this is it's truly an exciting time for cardiovascular imaging, for us to truly think about embarking on very large-scale clinical trials that we can truly drive quality imaging. So it's great, and it's great to have Dr. Douglas as a leader in this field.
Thank you very much.
So I'm glad we had this conversation, and I can see that there'll be very exciting things coming up from the participants of this workshop. And I hope the audience enjoyed it as much as I did, and we look forward to great discoveries in the field of imaging. Thank you very much once again.
Thank you,
You're
Chandra.
welcome.